by Providence Holy Cross Medical Center and Comfort Keepers in Home Care. I'm Barbara Cochran with my co-host,
Hi, I'm Dr. P.
Dr.
Follow me on TikTok at Migraine Relief Mastery.
Say that again?
Yeah, okay, sure. I'm Dr. P. Follow me on TikTok at Migraine Relief Mastery.
Oh, okay. All right. Well, Dr. Thomas Palaki on your hometown station, 98.1 FM, AM 1220 KHTS. This is a show for, about, and by seniors, giving information to enhance one's quality of life. And our guest this afternoon is Sandra Wellerman. She is a nurse practitioner at Providence Holy Cross.
Hello.
Hi, it's good to see you again.
Thank you. Good to see you guys too.
It's been a long time.
It has been.
Well, it's every fifth Wednesday. Right?
Yeah.
So, what's on the agenda today?
I think we're going to do a little bit of kind of what we always do is education around what's palliative care, what's hospice care, and the best ways to support patients and families in this area. So yeah, happy to be here. Thank you for having
Thank
me.
you. Thank you. So, okay, so the burning question is, most people have no idea what the difference is. I know I don't. I've learned a lot from you, but when it gets personal,
Right.
it changes everything. So, specifically, what is palliative care? And what is the difference between hospice care? And does that have a universal meaning, or can there be like 50 shades of palliative care, 50 shades of hospice care?
Yeah.
Is it disease dependent? Is it regionally dependent? Is it the facility that or the group that you're working with dependent? So these are things that I don't understand.
Yeah. So there is universal definitions of both palliative care and hospice care. So you know what they are overall, but the beautiful thing and maybe the confusing thing about palliative care and hospice care is it's very individualized for that specific person and that specific family. So for palliative care, it's really any person who has a serious illness at any stage of that illness. And really, they're going to be dealing with this illness for the entirety of their life. So we get involved to support that patient and their family to make sure that they understand what that illness is, that they can have a good quality of life living with that illness, that we understand their medical wishes, what they would want and what they would not want, and really individualize their care. But they could be on receiving palliative care for many, many years as they live with a chronic disease.
Now, what does that mean? Palliative care. Does that person come to the home of the person who's ill?
It depends. Like, just like any type of care, there's inpatient care and outpatient care. So there's, an inpatient palliative care service that might get consulted if you're in the hospital. When you're home, sometimes there's palliative care groups that see patients in the office. Other times there's home-based palliative care groups that go and visit patients in the home.
Now, does that include a doctor?
Yep, it's a team, doctor, nurse practitioner, nurses, social worker, chaplain. So that's
Now,
all part of the team.
is that the kind of thing you do? Being a nurse practitioner?
I work in the hospital, yeah.
You do?
So I work solely in the hospital, but we do have a group that works outside of the hospital and goes into people's homes.
Okay.
Yeah.
But you see the patients in the hospital?
In the hospital,
Absolutely.
Yeah.
Nothing else. You don't
Correct.
go home.
Yeah, correct.
Okay. All right.
And then when you talk about hospice care, that's when things get a little bit more individualized. There is a criteria for a person to qualify for hospice care, and that criteria is designated by a doctor or a nurse practitioner. And it's really basically two things. They have to have a disease that has a prognosis of 6 months or less. So they have a terminal illness. where their likely, lifespan is around 6 months or less. So that's one. The second is their goal of care now is not to receive any more treatments to treat that disease. Now their goal is just to focus on their quality of life and their comfort.
And that can be done in the hospital also.
It could be done
Yes.
any area depending on really what the patient needs and what level of care they need. So if they are very, very symptomatic and they need to be in the hospital because really that care needs to be in the hospital, it can't be provided outside of the hospital, then they could be on hospice in the hospital. But
Yeah,
the vast majority of times it's outside of the hospital, either at a nursing home or at home.
Yeah, because Russ was in the hospital for 5 weeks.
Yeah,
And the doctor wanted to put him in a nursing home,
right.
which he said,
Yeah.
that was the last place Russ wanted to go, was a nursing home.
Yeah,
And because he had always told me, if something happens to me,
right,
don't put me in a nursing home.
right.
I'll stay at home.
Right.
And we had long-term care insurance.
Mm-hmm.
And they did come into the hospital and help with him when I had to go home. Because I needed to sleep also.
Right,
They
right.
didn't give me a bed there to sleep in.
Yeah.
So that was the hospice care that Russ had. And he had it in the hospital.
Right, right.
And they were very good. They really were.
Yeah. Good. So you can see how the hospice care can be a little bit more individualized because there's, two people could have the same illness and have the same prognosis, but one could want to continue on with more treatments. Another one could say, I want to only focus on my comfort at this point. So that's how that can be more individualized based on
Okay,
what
so
the
I got a
patient needs.
question because I'm already confused. Sorry.
Yeah, that's okay.
I thought I heard that hospice is there are no more treatments. It's just giving them
So
comfort.
the patient is not going to pursue disease modifying treatments. So that
Okay.
could either mean there are no more treatments available.
Gotcha.
And now that person really doesn't have many options. The only good option is for their comfort.
Right.
Or it could be a situation. I mean, we've had patients, I had one recently that she didn't want to do treatments.
Right.
She decided, I don't want to pursue a diagnosis. I know
Right.
it's cancer.
Right.
I don't want to pursue a further diagnosis. I don't want chemo. I don't want treatment. I just want comfort care. I want hospice.
Yeah.
And she went home on hospice.
Gotcha.
So it's just that person's based on their goal, because everyone's different. Some people want to continue with treatments for as long as humanly possible. Others don't. So
Yeah.
that's where the individualness of this field of medicine comes into, where we're really getting at what's your goal, who are you as a person, what's important to you, and how can we best support you in that.
Okay, so I have some, I don't know, it's just, like I said, when it gets personal, you need to know some things. So how much of this is determined by the patient and their immediate family, and how much of this is determined by the insurance policy? I hate to say it, but this is real.
As far as like the hospice part of it?
all of it, all of it. Do you have to? I mean, do you have to jump through special hoops to get palliative care? Do you have to, and then who decides what is palliative? What really is the person's chance of the 6-month prognosis? Where does all that, or that's really not part of what you're involved with?
Yeah, well, there's a few things. I mean, first of all, most insurance companies are having more palliative care services offered. I would say the majority. It's very few and far between that a patient can't get a palliative care service as an outpatient. It does happen every once in a while, but most of the time they do have a service that works with that insurance company and medical group. Now, the different programs can differ, just like in medicine. It could be the same service, and depending on what group you go with, you could have a different, level of care. But most do provide that. As far as like the prognosis and the options for treatment, that's going to be specifically from a physician. A lot of times, whatever's going on with you, if it's cancer, it's going to be an oncologist saying, we've worked things up, this is where we're at. Here's your different options for treatment. Here's your prognosis with or without treatment. And then it's really a shared decision making with the patient and their family. And that's where palliative care comes in at that point, to make sure that the patient and the family understand what's going on, understand their different treatment options. Because a lot of times people hear chemotherapy or treatments and they think it's going to be curative. And a lot of times, sometimes it's not curative. It's just what we call palliative intent, which means that the cancer has progressed to a point where it's not going to be able to be cured. Now, any treatment is just to slow the spread of the disease and to give the patient more time. So we do a lot of that education, and yeah, a lot of it's shared decision making and getting to the bottom of, making sure they understand where they're at, what their options are, and what's best for them.
Gotcha.
Yeah.
So, okay.
Does that make sense?
Well, it does, but there's still so many questions. Like I said, just talking in general,
Yeah.
it's amazing the information that you're providing. But when you're faced
Yeah.
with dealing with
Yeah.
it personally,
Yeah.
all of a sudden
Yeah.
everything sounds like Charlie Brown's
I
teacher.
know.
Want, want, want,
Yeah.
want, want, want. And you're like, but I still don't get it.
Yeah.
I still,
Yeah.
so I imagine there's some kind of tables somewhere that these decisions are made on. I understand that the success rate of a certain surgery for, let's just say, something that I treat and I have a great success rate, I know exactly what's going to happen if instead they go to a surgeon, because there's statistics on this. Is that how this is handled as far as, I imagine a great deal of people facing these decisions are dealing with cancer. It's a big one, because if they had a stroke or if they had heart disease, it's going to go a different way. But cancer is a different disease process altogether, and so is dementia. So these are going to lend themselves more to long-term, whether it be palliative, whether it be hospice. And I think this is where the confusion, like, how do you know? How do you tell somebody, well, you've got 6 months to live? I mean, where does that come from, literally?
Yeah, yeah. And there is, like you said, there is specific, equations that we kind of go through to guesstimate how much of a prognosis a person has based on what's going on with them. But that's the thing that I tell people, is this is our best educated guess. And there's a lot that goes into how long a person is going to live. And a lot of that, frankly, is like out of our hands. We can make a educated guess and we could provide them with their options. But then I've seen everything. I've seen people, pass quite quickly that I thought were going to live for 3 or 4 more months. I've seen other people with, profound disease live for much longer.
Right.
So this is really just our best guess, but we don't know. We're just providing this information to help people make the best decision for them. And then I always say, go live your life. Don't be, marking down the days on a calendar. We don't know. So, this is the best we can do, but go and live your life. And if you're on hospice and you start doing really well, which some people do, and they decide, you know what, I want to go be reevaluated for treatment. Hospice is not like a one and done thing. You can disenroll, you can go back and see your oncologist, get reevaluated. This is just, the best information we have in that moment of time. And then, you take it one day at a time.
Gotcha.
one
Yeah.
day at a time. And
That's where we all are.
Yeah,
really.
exactly. Nobody
That's-
knows the future. We don't know.
That's very important.
Yeah.
Taking it one day at a time.
Yeah.
You know, because I've had cancer twice.
Right.
I got it in my 70s, and I've had it in my 80s, and I told
Yeah.
the kids, if I get it in my 90s, I'm going to beat it again. But you have to be
Yeah.
positive also.
You do.
Being positive
We do. You
makes a big difference in
It
your
does.
life.
It does. It does.
It really does. It's almost a 98 percentage. It really is. To be positive and think ahead that things are going to be okay, you know, because you can really pull yourself down if you're negative. And I think that was one of the things that happened with Russ, because Russ was, as you know, Tom, he was more of an on the downside, more of a negative person. And I was always a positive person. And I think that helped keep him going a lot.
Yeah, that's why you were put together.
Yeah, I'm sure it is. I'm sure it is, because it was very interesting. I mean, he was a school principal, and then he went into the district office up here locally. He did it for almost 40 years.
Right.
And but he was always good at what he did, and he was good with picking people up, so to speak,
Yeah.
instead of pushing them down. Yeah, you can do this. You can do this.
Love it.
And that was the difference between the two of us. But with me, I've always been a positive person. I've always felt that good. Tomorrow's going to be here, and I'm going to be here. Nobody's going to change my mind. And having survived cancer twice,
Right.
to me, is positive. It really is. And I think my attitude had a lot to do with it. I really do. It's it has saved me,
Yeah.
being a positive person.
Yeah, it's a big part of it.
It really is. And
It's really the best medicine there
I
is.
took
It
after
is. It
my
is.
I took after my dad. He was always a positive person. My mother was always the negative one. So that was a good combination
Yeah.
also,
Yeah.
because he helped her, even though they both passed away when they were 70. And I dreaded the year I was 70,
Right,
because I thought, uh-oh.
Yeah.
Am I leaving too?
Yeah.
But I'm still here, and I'm
Yeah.
headed very close to my 90s now.
Yeah.
So, and I don't intend to give up at all.
Yeah. Yeah.
Not worth it.
Yeah. For sure.
Life's
so-
worth living.
Yeah. That's the part we really can't account for is
Right.
people's spirit,
Yep.
in all honesty. And I've seen
Yes.
it time and time again, like you're talking about, people with a strong spirit just outliving, situations that we thought medically don't make sense.
Sure.
So, that's why this conversation is very nuanced and
Yeah,
There's
and
a lot
that
of-
brings up my next question.
Yeah.
When is your involvement, and when I say your involvement, I mean
Yeah.
when is palliative care
Yeah.
appropriate? When do you get the call? When
Yeah.
should somebody be asking for you?
yeah. Well, when we get the call and when we should get the call sometimes are two different things.
Yeah.
Oh,
But we're
yes.
getting better
Yes.
because when we should get the call is really, in the best case scenario, at the diagnosis of a serious life-limiting, potentially illness. So really at that diagnosis of cancer, that the cancer has a aggressive nature or whatever. So that's the best time for us to get the call because we're very minimally involved at that point. We're just making introductions and maybe working on symptom management and developing a relationship. But really the primary is going to be that physician who's treating that disease. But then we follow along and become more and more involved as the disease progresses. So that's the best time for us to get involved because we can really make the most impact and give the most support. But we get, consulted at all various stages of illness. A lot of times we get consulted after a few different treatments have happened, and now the patient's running out of treatment options, and they're experiencing much more symptoms and things like that. So
But you're there if needed.
we are. Yes.
And that's the important part.
Yeah, one quick question because we got to
Yeah.
go to break real soon, but
Yeah.
I want to know. So, we know that Barb's living proof that there are improving statistics on cancer. However, there are no improving statistics on dementia.
Right.
So, I mean, should it be an immediate palliative care situation, in your opinion?
So, a lot of the home based palliative care follow dementia patients for many, many years.
Got it.
So, yeah, I mean, they could, and the home based palliative, they do a consult and an assessment, and they rate people on like levels of care. So, sometimes when they aren't high on a level of care, they'll see them like once every 3 months and have a nurse line to check in. And then as they get sicker and sicker, they start ramping up the visits. So it's appropriate, at least to do like advanced care planning and make sure the family's supported and
Got it.
understands the disease process. Yeah.
Sandra, sorry.
Yeah.
Sandra Woolman, palliative care, nurse practitioner, Providence Holy Cross,
Yes.
and something else too? Or is it just at Providence?
Just at Providence,
Okay, all right, okay.
yeah.
You've been listening to Senior Hour KHTS, FM 98.1, AM 1220, hometownstation.com.
Dr. Neil Green has been treating Santa Clarita patients and making them smile for over 35 years. As a child, Dr. Green had a fear of the dentist and disliked even simple checkups. But today, he's sensitive to your needs. If you have anxiety about getting a checkup, he understands your apprehension, even if you've avoided the dentist for years. Discover the comfort of visiting a dentist with Dr. Neil Green. Dentistry is his profession. People are his focus. NeilGreenDDS.com. That's Neil, Neal, GreenDDS.com.
There are many memorable restaurants in Santa Clarita, but 3 words stand out from the crowd. Mom can cook.
Mamá puede cocinar.
Mom can cook the best Thai food on this side of the planet.
Mama fait la cuisine.
No matter what language you use, Mom Can Cook says it all. Thai food at its finest, all your favorite dishes, and Mom's very own original specialties. Experience it on Soledad.
Wallerman, who's a nurse practitioner at Providence Holy Cross, one of our sponsors. And what's on the next subject?
Hello. Yeah, I think we were going to talk a little bit
Yeah.
about.
So specifically,
Yeah.
what are the services in palliative care? Like, so it is a step up. As soon as a certain trigger is reached, which is a serious, lifelong condition, you should be consulted on this. Your team should be activated. So I have a couple of questions. One, who's on the team? And 2, what exactly can someone expect once your team gets involved?
Right.
Yeah,
right.
this is different from hospice care.
Yeah.
Yeah.
This is a step below hospice care.
Right.
Yes,
Right.
Palliative care.
Yeah, so the main thing to know is that palliative care comes alongside all the other medical specialties. So we concurrently work alongside with all the other physicians that are doing aggressive curative treatments. Every palliative care team might look a little different. Ours at our hospital is a physician, a nurse practitioner, and 2 nurses. Other services might have a chaplain involved or a social worker involved, but there's always definitely a physician and, a nurse and maybe a chaplain or a social worker. And then what you can anticipate is really individually based. So depending on what that patient and family need, what their questions are, where they're at in their disease process, it's very individualized. And so we really go in and we do a comprehensive full assessment. We really do whole person care. So we look at what's going on with the patient medically, what symptoms they're experiencing, what might be going on with them socially, spiritually. We look at if they've done advanced care planning and done an advanced directive and a POLST form to speak about their medical wishes for the future. So we really do a comprehensive assessment, and then based on what that patient and family need, that's the care we provide.
Okay, now your group does include
Yeah.
a doctor. And what is a nurse practitioner as opposed to a nurse?
Yeah.
What's the difference there?
Yeah, so that's me, a nurse practitioner on our team. And what a nurse practitioner is an advanced practice nurse. So I'm a provider, so I'm able to diagnose, treat, prescribe medicines for different conditions, and I work under a physician.
So you're the next step to being a physician then.
Right. So I work under a doctor, but always with that, nursing
And
perspective.
is there any reason why you didn't go on to be a doctor?
I mean, I considered it, but I'd been a nurse for a while, and I like working in the nursing type of holistic perspective of things. So that's why I decided to just go on and be a nurse practitioner.
And did that require extra education?
So
did?
I became a registered nurse, and then after that, I got a master's degree in nursing and certification to be a nurse practitioner, and took boards and all of that.
A nurse practitioner. So you're the one step below a doctor.
Right.
Now, what would it have taken for you to become a doctor?
Yeah. Medical school, residency, boards, all that stuff.
So much more.
Much more.
Yeah,
Much,
so-
much more. Yeah.
Another 6 years on top of
Oh,
that.
yeah.
Whoa.
Yeah.
So,
That's a
but
lot.
there is a lot of autonomy now with the nurse practitioner.
There
I mean,
is.
you can do a lot of stuff that used to be exclusively in the field of the MD.
Right. Right.
So, is it appropriate to talk about some of that, or should I just get back to what I want to know about palliative care?
I could talk about it
Pretty
just
selfish about this
slightly,
one.
but just in case anyone's curious. But yeah, basically it's state by state. So different states in the United States have different laws based on how independent.
That's crazy, you know?
Yeah.
It should be states wide,
Yeah.
the same requirements.
Yeah.
And
Yeah.
why it isn't is beyond me.
The requirements to become an NP are the same, but
Yes.
the level of independence and autonomy you have are different based on what state you live in. So in California, you do need to work under a physician. In other states, you can be completely independent. So, so in California, I do need to work under a physician and consult with that physician and have her basically, sign off on what I'm doing and, take kind of responsibility for the care that I'm giving. But other than that, I'm pretty independent. I have my own DEA license and everything like that. I can prescribe medicines on my own. I just need that physician consulting and signing off on everything I'm doing.
So you
What
like
is
have
it-
a medical director,
Correct.
What is a
Yes.
DEA license?
drugs.
Yeah.
Drug
to
Enforcement
prescribe.
Agency.
Yeah.
Oh, interesting.
Yeah, whenever there's an acronym, like
Gotcha.
it's short. We always use shorthand to talk because the actual
Everybody
verbiage
knows.
can get, to be a tongue twister.
True.
but
but most
not-
doctors and nurses and practitioners know those.
Yeah, terms. Yeah,
Terms.
Yeah, but not everybody does. So you didn't.
No, I didn't. What was that? Or what is that?
Okay, I want to jump back
Yeah,
about
for sure.
5 minutes in the conversation because you talked about a couple of things that I think are critically important. Advanced Care Directive.
Yeah.
And you said a pulse.
Yeah. Yeah.
So
So
please.
so I'll elaborate on these two forms, especially because we touched a little bit on dementia. And dementia is a, disease that people know your mental decline is significant over time. So these forms are important, especially in a disease like that, where you can lose your ability to make decisions for yourself. So an advance directive is really a document that you complete that states who you would want your medical decision makers to be in the case that you couldn't for yourself, and some of your medical wishes around end of life and things like that. You have to be cognizant to be able to sign for yourself. And normally you have 2 witnesses sign for you as well.
I got a legal question,
Sure.
and I don't know if this is appropriate or not, but once you have the diagnosis of dementia, are you cognizant? I mean, who determines that?
Right,
And
right.
and who determines what the the cutoff point is about who's making decisions on what and when?
You know, I think with the advance directive, it gets notarized. So I think as long as the person is able to, you know, be alert, oriented, state their name, they're not confused, and they know what they're doing, they're able to sign for themselves.
Well, that can happen for a few minutes, even in advanced dementia. You know, it's when you catch them.
Right.
So
Yeah.
that's a little bit of a gray
Yeah,
area.
yeah. So normally when a patient has, you know, dementia, we go towards the POLST form, which can be signed by a family member.
Got it.
Now, can you put that in a trust? Does that
Yeah. A lot of people put the advance directive in a trust.
in a trust?
Yeah.
And does it say advance directive?
Yeah.
It does. Okay.
Yeah.
Yeah, so that I think should be an important point to make. If you have a trust, and you should,
Yeah.
this should be in your trust.
Right.
And whoever I have a trust, and this was not even brought up. It is not part of, I guess, the template, the boilermaker, the template that the attorney, a good attorney,
Right.
you know, had us like, I mean, down to pet care and all this kind of stuff. But
Right.
the advanced directive never came up.
Yeah, yeah. Yeah, so we don't know what's going to happen in the future, you know, especially like you say with patients with dementia and stuff. So, you know, good to do for everyone, no matter
Yeah.
what's going on with you, just so you can make your wishes known and set the people that you want to be there for you to make your decisions. So that way, nobody, you know, God forbid, if you're diagnosed with something like this. You don't
So it has to specifically say advanced directive.
yeah.
Well, there is a form, no?
forms, yeah.
So there is legal forms for this. It's just apparently you have to specifically ask for it because it's not part of the process.
Gotcha.
Yeah.
Okay, I'm
Okay.
gonna have to look at my trust.
Yeah.
See whether I have one in there. I know I have my daughter
Yeah.
doing all kinds of things that from A to N,
Right.
you know,
Yeah.
things like that, because she is the trustee,
Yeah. Yeah.
and
Yeah, so definitely
in-
recommend that for anyone, irregardless of your, you know, state of health. Important to do.
Yeah, it should be part of every trust.
Right.
I think it should be standardized. You know,
Yeah.
especially if you're thinking ahead in those terms. This is something that is kind of important, no?
Yes, definitely.
Yeah.
Definitely.
Okay.
yeah, I have to check it out to see whether it's in mine, because I was in the hospital a couple of weeks ago with bad sore throat, and I had an upper respiratory infection. That's what they after 5 or 6 different tests over at the at Henry Mayo.
Right.
That's what they said I had was
Yeah.
upper respiratory infection, and put me on heavy duty medication,
Right. Right.
which I finished yesterday.
Oh, good. That's good.
So, and thank goodness I feel good.
Yeah. That's good. I'm glad.
I've been out walking up and down the street,
Oh,
so
good.
I am getting good exercise. So
Yeah. Yeah.
I try to do that every day.
That's good.
But I still have a funny sounding voice. I can hear it.
Oh. I didn't notice it.
It's not back to normal yet.
Yeah.
So,
Take
but
some time.
I'm doing good. I feel good.
good.
Thank goodness.
Yeah.
I don't like being sick because I'm never sick, really.
Right.
Very, very seldom ever.
Yeah.
My biggest problems was the cancer stuff.
Right.
And who would have thought that? You know, where did that come from? But it came from methotrexate. That's what the doctor said. That was the possibility.
Gotcha.
And they didn't know that when I was taking it.
Sure.
They just did a lot of research and found out.
Yeah. They saw that
So-
happened.
So I don't do methotrexate anymore.
All right, Sandra.
Yeah.
What kind of palliative care can a family member expect? You know, I know that your patient is the primary concern, but palliative care goes beyond the physician-patient relationship because everybody has to deal with this.
Yes,
So
yes.
what does the immediate circle of influence,
Sure.
what can we expect?
Sure. Well, first of all, on our initial assessment, we figure out who family is for that patient. We ask the patient who they would want to be their decision maker in the case that they couldn't make decisions for themselves. And then we always reach out to that family and get a better understanding of what their understanding of everything is, what they need, what they might need in regards to like caregiving, and make sure they understand the disease and the disease process. And then sometimes, frankly, it's us communicating directly with the family and barely even communicating with the patient because they're so sick they can't speak for themselves. So a lot of times it's really, us communicating with them on behalf of the patient.
Gotcha. And is this unique to your team, or that's the way it's supposed to be everywhere?
That's the way it's supposed to be everywhere. Yeah.
Now,
Really?
For the palliative care, yes.
Now, do you have family members that disagree with each other?
Yes,
when
we
you're
we run into that quite a bit. Yes.
How do you handle that kind of thing?
Yeah, it's
Or
tough.
should we wait? Should we wait and
It's, we just take it on a case by case basis, basically. But hopefully, the patient is either had an advance directive done and we know who the primary decision maker is and who really to defer to, or the patient is cognizant enough to be able to say, I want this person to be my medical decision maker and everything. So that's kind of how we go about things. So that doesn't always happen. Sometimes, we have to deal with it on a case by case basis, basically. But that happens quite a bit.
I would think that would be very unnerving
Yeah,
to have family members squabbling
yeah,
over how to take care of a significant other.
it's
or-
tough.
Oh my
There's a lot of
goodness.
feelings. Yeah.
Oh yeah.
All right, if you're like me, I think you still have some questions for our very special guest, is Sandra Wollerman, palliative care specialist at Providence Holy Cross. We'll be right back at KHTS FM 98.1 AM 1220 hometownstation.com.
Fed up with your power company's high energy bills? Feel trapped in a one...
The most important one is that, is going to come up is it covered specifically for this audience? Is it covered by Medicare? Is it covered by Medicaid? How does one access palliative care in case that they're not automatically offered it?
So, in the majority of times, it is covered. If you're not in the hospital, I would ask your primary care physician to write a referral order, and that referral will go through your insurance to make sure that it is covered and set you up with a specific group. If you're in the hospital, you can ask your attending physician as well for a consult for us to come in.
Okay, so once you cross that threshold and the palliative care team is involved, what's the big difference? Like, what can somebody expect when all of a sudden they've got new people showing up in the room?
Yeah, right. Well, first of all, I make my introductions, let them know who I am, why I'm here, and I kind of ask them what's going on with them and what I can help with. So you can expect to get just a comprehensive whole person care from our service, and know that we are there to support you in what you need, answer your questions, make sure you have all the information to make the best decisions for yourself and your health. So really, we're there to serve you, frankly, and to make sure that that what you need is what we help you achieve, and whatever your goal is.
Wow, it sounds like you are the lead on this team. Am I right in assuming that? Like you are the front person that people see first?
Well, it's me and Dr. Kalani. So how we do it is, she's the lead, but we kind of split up our patient list. And then the patients that I see, I'm the lead, and she's kind of like overseeing what I'm doing. So
Gotcha.
yeah.
Yeah. Okay. You know, it almost feels like this should not be a special situation. Like this should be how modern medicine is done.
Absolutely.
Yeah.
Absolutely. I totally agree.
I mean, I don't run things. I'm famous for saying I just work here. It just seems like this is what everybody really needs. No?
And as you have alluded to in the beginning, you could hear this information, but you need it repeated in different ways as you start understanding things about yourself and what's going on. So that's really what's unique and beautiful about our service, is that we're really just going in, meeting people where they're at, and just making sure they really have good control of what's going on with them, and really that their goals.
They know what's going on.
Right.
And are able to articulate that. That's so important.
Yeah, and Providence Holy Cross is just an amazing facility.
Yeah.
So we're so fortunate to have it locally here. And I know that the reason that I was asking different questions earlier is because I know it doesn't necessarily work like this everywhere.
It doesn't, no.
And my very pointed questions were the differences that I'm experiencing with palliative care and what you talk about here, because I think you're providing what palliative care should be, and maybe it's not exactly happening that way everywhere.
Right. Yeah, unfortunately, you have levels of people and institutions, and it depends on kind of who you work for, in a lot of areas in life, and the culture of that, and if palliative care is really supported and encouraged to really.
Well, we're so fortunate to have Providence Holy Cross as one of our keystone sponsors. We're also sponsored by Comfort Keepers. You've been listening to the Senior Hour on KHTS FM 98.1 AM 1220, hometownstation.com.